Good afternoon, everyone. Welcome to the Behavioral Health Echo. Today is Friday, March 29th. My name is Andrea Hevler, and I will be the facilitator today. Before we start, we want to remind you that these sessions are being recorded for later distribution. However, the information that you see on the chat will not appear on the recording, so we definitely encourage you to add your names, affiliations, and email addresses. We'll use that information to confirm your attendance to this class. And especially if you're seeking CEs today, please identify yourselves. If you're joining via phone, and I know many of our providers do, please send us an email letting us know that you were here today. If you need captionings for this class, you may navigate to the bottom part of the Zoom window and click on the captioning options. As always, there is a post-session survey link that we will distribute after this class. Please be on the lookout for that. And remember, during the case part of the session, we will try not to mention or use any information that could help us identify the person that we are discussing. I know we all know this, but we have to remind our learners about that on each session. No PHI, please, no personal health information in the chat or in the conversation. And if you want to revisit the content of this class, remember you can always go to our Be Well Texas YouTube channel and access this session anytime. You may also invite others who probably are interested in the topic and were not able to make it today. And with that, we're going to move to some introductions from the Behavioral Health Echo team. Let's see. Dr. Aguilar, would you introduce yourself to the team, please?
Sure. Hello, everyone, and thank you for being here. My name is Clarissa Aguilar. I am the Director of Psychology and Training here at the Center for Healthcare Services and in Integrated Primary Care.
Thank you. Katie.
Hi, I'm Katherine Dondanville. I am an associate professor at the University of Texas Health Science Center and the director of the Strong Start Training Initiative.
Thank you. Dee Dee.
Sorry, a little trouble there. Dee Dee Stout, good morning. California, so we're still in morning, folks. I am adjunct associate professor at St. Mary's College, as well as have a private practice, Dee Dee Stout Consulting, where I practice holistic harm reduction psychotherapy with individuals, families, couples, whatever, and do a lot of training on top of that. Thanks.
Thank you. And our case presenter, Cindy.
Good afternoon, everybody, or everyone. Sorry, my name is Cindy Saucedo. I'm glad to be here.
Thank you. So with that, I think we can start sharing our didactics. So we can start discussing, presenting our topic today.
Awesome. Thank you so much. So I have the pleasure of sharing more about an overview of cognitive behavioral interventions. I want to just kind of share this in the way that next month, Clarissa is going to share more in this area. This is just a kind of an overview and a taste. And I've also put together some slides on resources to follow up for more in-depth training and support in this way. So thanks so much. I don't have any disclosures. Here's our learning objectives. So I want to start first with cognitive behavioral therapy is like a big umbrella term. And that within cognitive behavioral therapy, there are specific interventions. There are like motivational interviewing, contingency management, relapse prevention, cognitive behavioral therapy. Also, as we think about this umbrella, is something that is often done in conjunction with medication management. And it also is an umbrella that when we think about supporting the clients that we see, that includes, considerations for their intersecting identities, but also comorbid problem areas. It's not just exclusively focused on substance abuse. Okay, so some of the main principles for us to kind of ground us in is time limited. It's typically short term. There's a structure to it. It's goal oriented and it's problem focused. Therapeutic alliance is very important. Just because it's structured or it's short-term or goal-oriented doesn't mean that that we're discounting the importance of that therapeutic alliance. Each individual patient or client, we're gonna have a formulation, a conceptualization, and we're refining and updating that as throughout treatment as we're getting more information. It's highly collaborative. So our clients are active both in the session and between session. There's some practice and homework. Our goal is to help our clients have changes outside of the time they are seeing us. And so we need them to start to do practice and things outside of therapy, not just coming. We don't have a magic wand where they come, bing, everything changes outside. Okay. And a really important component is psychoeducation. We need to help our clients be their own therapists. We're teaching them a set of skills that they can use outside of therapy and beyond. So one thing for us to just kind of ground ourselves in is how we think about the connection between what we think and how we feel and how we act, okay? So one of the things that as I was preparing for this presentation, I was inundated, like many of you all, by a lot of news about Kate Middleton. And all the thoughts about what was going on, and then people were having emotional reactions and behaviors, and then we got a video that told us different information about what was going on. And so then people started thinking differently and feeling differently and behaving differently. The way we think about things impacts the way we feel and what we do, and that our interpretations are impacted by our lived experiences, our intersecting identities. And so part of the process as we're thinking about cognitive therapy is starting to slow things down. So we know that we've got something happens and we have thoughts about that. We can also have images about that, and we're going to have reactions, emotional, behavioral, psychological reactions. It's the thoughts, right? The interpretation that determines how we feel and how we behave. And so as we think about that example that maybe some of you can relate to, you may have your own experience of having those thoughts change and having feelings change about situations. So we're going to help our clients start to look at those thoughts. And I often talk about this in the way like most of the time our thoughts are like, brrr, we don't even realize all the thoughts that are happening in our head. We have to think about how to teach ourselves how to slow those thoughts down and look at them. Now, here's the thing. Many of our clients, our patients, and ourselves, our thoughts, beliefs, and assumptions are accurate. Many of them, right? And the focus on treatment is on the thoughts that are distorted, the ones that are causing distress, the ones that are interfering, okay? So the other thing is emotions are logically connected to thoughts, right? If you receive a beautiful gift, what emotion might come up, right? And our thoughts are usually just automatically accepted as truth, right? As facts. In CBT, we're really trying to slow that down to look at, is this thought realistic? Is this thought helpful? So I want to start with thinking about conceptualization as it relates to substance abuse. Substances abuse are very, very powerful behavioral reinforcers. And over time, those substances create positive effects, and they also have negative effects, right? So some of the positive effects of substances people may describe as, it made me have more fun, right? And some negative effects are, that it may help me to escape these negative feelings, right? So by positive, it is about adding, and by negative, it's about reducing, okay? These effects become associated with different internal, and external cues. So things in our environment. Internal might be thoughts, physiological reactions, but also things in our environment, okay? And so the core element of CBT is we're aiming to counteract that reinforcement. So that includes increasing contingency of non-use, building skills for reducing use and maintaining abstinence. That's their goal. And facilitating, engaging, and rewarding non-substance or drug-related activities. So in this presentation, we're really going to be focusing on that skill building and how CBT helps with that. So one of the things we want to think about is what is it for this specific client? So understanding what are the triggers, the things that are crucial for targeting specific situations and behaviors. So for example, maybe that there are some high-risk situations like liquor stores or areas in the environment where people, where they may be procuring their substances. And at the beginning of treatment and early recovery, part of what might be most helpful is to identify those triggers, those high-risk situations, and avoid them or minimize them. Okay? We're at the point where we have to learn skills in order to manage that better. This is what's called stimulus control, right? So these are strategies that to reduce interactions in the environment, and they can be crucial for developing resilience skills in challenging environments. They can be helpful in achieving initial abstinence or reduction effectively. And analyzing strategies like this clarify whether the drugs are used socially to enhance positive activities or as coping mechanisms for different situations or emotions. Understanding what is driving the behavior helps us to formulate and help think about how do we support our client in developing more skills in those areas. Okay. When we start CBT, one of the things that we need to do is assessment. And assessment is happening throughout this process. It's formal assessment, but it's also informal assessment and really thinking about what is it about this person? What are they thinking? What are the different triggers? What are the high-risk situations? Continuous assessment. We got to develop a working alliance. That's something that we're all really good at, is developing those relationships. And thinking about what are the specific goals for this client and how would we know when we're getting close to meeting those goals? So coming up with a way that you and the client can measure that and track that progress. We need to provide psychoeducation. So we need to provide a rationale for why we're doing what we're doing and how this might be helpful for them. But also there might be important psychoeducation on some of the interaction between using in the case we're going to hear about later today is, thinking about, it seems like this was an adolescent who was experiencing some emotional distress, and the first strategy that they used was self-harm, and then the self-harm stopped and the substance use began. So I wonder how that substance use is related to that emotional dysregulation, right? And so we may, as we learn more about that, there may be some important psychoeducation around that. We need to get buy-in. We need our clients to have hope that this can be helpful for them, and that they're willing to partner with us together. In CBT, we have a structure in the sessions, and that structure can be really grounding for clients and for us. We want to set an agenda. This is what we're going to do today. We've got goals that we're monitoring, we've identified, and that most of CBT sessions is focusing on how did that practice go? And let's review and refine and work together, and then assigning some new practice. So really the work is outside a session, and really working together on that. And what got in the way of not being able to do the practice when that happens, okay? And thinking about, like, how do we support them to do that? So some of what we want to think about is, what are the client's current problems beyond diagnoses? Like, what is not working? How would they define their current problems? How do those problems interact? What maintains those problems? What are the thoughts and beliefs related to those problems? What reactions are associated with the thinking? So when they tell themselves, I can't handle my emotions, how does that make me feel? Or if I'm not using, I won't be able to manage my feelings. Or how does that make them feel? What does that lead to? How do they view themselves? How do they view others? How do they view the world? What are they thinking about things? In CBT, we often use the term cognitive distortions. And what these are just brief statements that may not be accurate. They may not be helpful. They cause strong negative emotions or problematic behaviors. So, one thing for us to think about is like, what are cognitive distortions and what are they not? So oftentimes, we have some clients who really get stuck in asking questions. Why did this happen to me? Why, right? And so what we want to understand is what's underneath the question, right? If it happened because, or if I never know, what would that mean, right? What do they think? Why did it happen to them? What do they think? What do they think underneath that? Sometimes our clients tell us stuff like, well, if I do this, I could be hurt. And maybe that thing, they could get hurt. But I guess I wonder, like, what is the thought, right? If I did get hurt, then what? If I tried something new, then what? Or maybe you hear like, well, this incident happened because I was drunk. Okay, and so what do you tell yourself about that? What does that mean? Cognitive distortions aren't emotions, right? So sometimes we say, I feel helpless, right? But that's a thought, right? So I'm nervous around men. Okay, that might be a fact. You are nervous around men. Why do you think that is? What do you think is the thought? When did that start? So really kind of thinking about what is our client saying and helping us to kind of together identify the thoughts that are underneath that. We also hear things like behaviors, right? I never open up to anyone. I don't trust anyone. Okay, so what do you tell yourself about that? Why is that? If I opened up to someone, what would that mean? What are you worried about? What's underneath that? So we can take information we're getting from our clients and think about how to scaffold or build a bridge to helping them access their thoughts about what that means. What we want to make sure is we're not making assumptions about what that means. We don't know. They're the expert. They're the expert on their thoughts, their experiences, and our job is to facilitate this process. Most patients and clients, they're not aware of their thoughts or beliefs. So we're going to help them to identify them. And part of what we're also doing is really refining our conceptualization as we're learning new things about the client. Does that ring true? Does that make sense? Is this related to the social situations, or is it that their pattern of use might be related to escaping distress, emotional distress, and where is that coming from? So one of the things, out there in the world, there are just so many different worksheets and lists of different types of cognitive distortions. Sometimes they're called patterns of problematic thinking. And these types of handouts can be really helpful to introduce to clients in a way of helping them to externalize, start to identify thinking, and also to think about what do they do more often. So I often take, handouts like this and think about, okay, let's look at some of the thoughts that are coming up and understand what fits under what category. And that most of us are specialists and that we do one or two things a lot. And you're going to notice, client, that your people around you also do these things. Like maybe you might notice that your partner does a lot of mind reading, right? They think they know what you're thinking. And sometimes we do that. And we do know what somebody that we know really well is thinking. But sometimes we're wrong, right? So thinking about like developing a sense of curiosity and identifying what are the things you do more often in a non-judgmental, blaming way, but a curiosity. I like to point out under exaggerating and minimizing, if you ever say, it's fine, doesn't bother me, I'm okay, it's not 100% fine, and it does bother you a little bit, right? That's minimizing. How does that impact the other person knowing that you might need support, right? And sometimes you might notice like patterns like that exist in your family. And maybe that's kind of a message that, you've observed people in your life also saying, there's even silly pillows that say, it's fine, I'm totally fine, right? To make fun of this idea that we're minimizing, and that's not exactly what we feel. So we have to slow things down. Another thing that I think is helpful, this is just an example kind of worksheet about, just starting to notice thoughts, like slow things down. We don't really notice. So oftentimes in CBT protocols, there might be some mindfulness exercises. One of the things about mindfulness, it's so helpful in starting to kind of notice thoughts. And you may have been done some exercises where you try to kind of let those thoughts go down the river. And for some thoughts, that can be so helpful for. But other thoughts is almost like they get stuck like on a lazy river, and here they come again, and here they come again. Just watching them may not be the most helpful way to work through it. In the therapies that I do that are focused on post-traumatic stress disorder, we often call thoughts stuck points that might help us differentiate that they might be stuck in some way. And I really like language like that. The other thing is like, we want to work with our clients to help them to identify those problematic thoughts, those stuck points. And so many of our clients may not know what the thought is. We can work backwards. So what's the feeling? Okay, if they're feeling angry, what might be the thought? What might be, who or what are you angry at? That might help us determine kind of what's the thought underneath it. So with anger feelings, I like to ask that question, who or what is this at? And it'll surprise you. They may say myself, oh, tell me more. That may help us understand what the thought is. But also, like, if the thought is guilty and if the feeling is guilty, does the thought that they're offering up, does that match that feeling? And so we might be going back and forth. They might say, I should have known. Okay, well, when you have that thought, what feeling comes up? Angry. Yeah. Okay. So what might be the thought that's leading to guilt? What's underneath that? Okay. Why do you feel guilty? What do you feel guilty about? To whom do you feel angry? Why? What are you afraid of? What do you think would happen? What's the worst case scenario in your brain? What does your brain say? These are just strategies to help kind of partner with our clients and start to slow those thoughts down. The other piece of things is that emotions are a really big part. Being able to identify emotions is challenging. Sometimes it's like, I don't know, I just feel uncomfortable. And many of our clients are not going to be, we don't need them to be experts at any of these things. We're going to partner together to help figure out what's keeping them stuck. And when we look at the feelings, we can think about different dimensions of feelings, right? So I might be like a little bit down versus sad versus depressed, right? And rage could be feeling irritable versus angry versus enraged, right? So they can have different intensity. And then the other thing is that we, in our language, and I do this too, and this is how I speak with my clients, is I'll say, I feel stupid, right? And I do feel stupid sometimes, but actually, there might be an underlying thought that I am stupid, right? And that actually leads me to feel shame, right? So words like hopeless, worthwhile, alone, stupid, we tend to say, I feel, but those might be thoughts. And it's important for us to separate that, because when we are able to identify our thoughts, then we can start to look at our thoughts. So a thing about emotions is some emotions are a result of our thoughts. And so if we have more accurate thoughts, those emotions change. Other emotions stem from the event itself, and they're universal, they're natural. We need to move through them, right? So if our friend overdosed and died, and I have a thought, I should have been there to save them, right? I'm going to feel guilty. But also, my friend overdosed and died, right? I miss them. I feel sad, I'm grieving. And that guilt, right? The thought I should have been there might actually prevent me from being able to grieve their loss. We want to work together to think about how to identify some of these problematic thoughts. Not only can we work backwards from emotions, but we can also look at behaviors. So we can look at, okay, what are the things, right? Well, I didn't want to go to school this week, or I'm avoiding crowds. I'm not returning phone calls. Okay, what do you tell yourself about that? How do you feel, right? So we can really kind of think about how do these things interact, and think about what are the things we could consider looking at changing to help our clients move closer to things that are important to them. A big part of CBT is practice, and we do that through different worksheets. I'm just going to show a few examples. One example is an ABC sheet. This is, not, there's many different versions of it, but what I like is it just kind of slowly, like, what happened? What are my thoughts? What are my feelings, right? Feeling word is like one word. And then there's like a little bit of challenging down there, right? So is that thought and be realistic? Is it helpful? Is there something more helpful? I'm also providing some links if you want to watch some videos that can be shared with clients on like how to fill it out, right? An example one. I know that this is a little blurry, but what I like about this sheet is like, it doesn't have to be so fussy, right? We could just put the thought in a circle in the middle of a sheet and then come up with all the different other ways to think about it. It doesn't have to be so fussy, right? And so we don't have to have these amazing worksheets. We can make it simple for our clients. The goal is to kind of look at a thought and then take a step back, right? And look at the different things to think. So I provided, there's some links. This it's got a series of trainings. This website's got tons of information about research, demonstration videos, treatment manuals. These were two really great free articles that could be helpful for you all, and just want to kind of say this is just a very small intro to kind of the umbrella, but also some specific things that you can take away now for thinking about the work that you do with your clients.
All right, Didi, you wanted to say something?
Nope, that's just clapping.
Okay, great, wonderful. Let's see. Do we have any question, comments around that interrelation between thoughts and emotions? Great material. I'm sure that some of you may have some comments and questions. Like she mentioned before, like our speaker, Dr. Dondanville mentioned, we're going to have a second part because it's such an extensive topic and such an important resource, cognitive therapy. Anyone? Anyone in our audience who has considered or has used cognitive therapy with their clients or patients, maybe without knowing? Oh, Pastor Debbie, go ahead.
Thank you. I had a quick question and thoroughly enjoyed that presentation. It made so much sense. My question would be, you're working with a client and in that setting, you're a therapist. Is this client working alone or in tandem with a family or community? Are they a reliable reporter? Or what if there's someone splitting that comes in and doesn't bring in all of it? Or is it better to work with them one-on-one and only hear their truth and set them down? And then how does it circle back out into family and wider circle? How does that come through?
Yeah, so I think like all are out there, right? So I think involving family is really, really helpful. And thinking about like what is important to that client, like what would that look like? How do they want to involve family? What are some of the family goals and worries? And maybe some of the family members could benefit from their own support because they may have their own reactions and thoughts and things that they're struggling with that is making it hard for them to be the supportive family member that the person needs. I think
Thank you.
that,
I just wanted to follow up and say, here in this congregation, we so rarely see one person in a family that's isolated with this problem person. Sometimes the families say that this person, they're not good. Can they be in respite here? But what we find out when we work with the person is that it's a constellation of people that it might have been in this one subset of unwellness. And so I just wanted to be real clear about that. And thank you. I took some notes and I really appreciate this. And it was very insightful. Thank you.
yeah.
Well, if we don't have any more questions or comments for now, it's okay. We're going to move very quickly to the announcements, and I'm sure that we'll go back to this topic when we discuss the case. So, Karen, can we share our very short announcements of the day? And just a reminder to any of you, if you want to present a case for us here at CSTAT, the Center for Substance Use Training and Telementoring, we offer you the opportunity to present any case. It could be a challenging case, a present, a past case, but it's a great opportunity to hear a group of experts giving you insights and alternatives to manage that case. It's very easy. We'll provide you with the case form. So you won't have to do much, but just fill out a form. If you want to present a case for us, please send us an email at cstat@utesca.edu, and Karen probably is already sharing that email address. Next slide. And remember, this is a seminar. This is an 8-part seminar. It has been so well received by all of you. This third session, actually the fourth session, it's going to be on Wednesday, April 17, and it's Dr. Houston talking about compassion fatigue. And I'm sure that all of you felt at some point related to compassion fatigue and burnout and all that. She's going to be sharing some strategies to work out through compassion fatigue and burnout for behavioral health professionals. That is Wednesday, April the 17th. We're sharing the link on the chat. The whole webinar and the 8 series are completely free, and we offer CMEs and CEs. So we invite you to participate. We're having great speakers. Thank you. That should be for our announcements today. And I think we can move to our case presentation of the day. Cindy Campos Saucedo, if you're ready, you can walk us briefly through your case. Thank you.
Yes, absolutely. Thank you so much. So yes, hopefully I stay within the time frame, but I am so eager to see if there are any other comments in regards to this case. The agency that I represent offers services mainly geared towards either the prevention, the treatment in this case of substance use. So we're heavily focused on substance use only. So right now we have a 13-year-old female that identifies, as you can see, heterosexual. And some of the things that the counselor is, including in there is that there's some negative views as far as mental health services or the treatment of it. As you can see, some of the difficulties that we have been seeing is some treatment adherence, primarily at the beginning. And this client engages in high-risk situations and can also disregard personal safety for when she engages in the substance use as well. So she has engaged in self-harm in the past, but the last episode was only, or the last one reported at age 11. And like most of us, I'm pretty sure we've heard, the substance use was primarily used as a coping skill. Right now, some of her views, specifically just with the substance use, is as an experimental process, in addition to the coping skills, or as a coping skill, sorry, which at times does lead her to believe, again, in the pre-contemplation, the contemplation stage of change, that, hey, no, there is nothing going on, I'm all good. However, currently, unfortunately, now they have been moved, or they are moving into finding, right? She has accepted into finding some of the good things, the positive things, as far as why the use should be discontinued, or how the use, if it were discontinued or even decreased, could be good for her. A little bit of background as far as what the client has is family or parents are separated, but the support from both ends, it's there. So the stepfathers or parents, sorry, as well as mom and dad biological. Only one trusted friend, and this is something that this client has primarily, and even from I was also taking notes from the presentation because of that, right? 13-year-old, I don't trust anyone. I can only speak or talk to this one friend that, in this particular case, it's still good. One person is better. than none. And she has expressed some interest as far as, when the counselor engages and what could potentially be at a different and or an alternative, positive and healthy coping skill, some interest in sports. However, the youth has not, been engaged or is not engaged either at school or outside of school in sports, but that's something that she does with her other siblings at home. And also she is very expressive through arts and crafts projects as well at home and or at school. So some of the interventions, yes, of course, not entirely like the presentation and all the approach or the interventions in CBT, but she has been receiving that most definitely, also motivational interviewing. And again, thankfully, from the beginning to today, there has been change from the pre-contemplation to at least, hey, you know what, maybe I should, or the fact that she has or she's been working with the counselor in identifying at least the pros of making a change in the substance use. Yes, there has been some psychoeducation services, not as intensive or as extensive, rather, with the family, in this case, parent, and without her as well. The main substance of use have been cannabis for at least the past 2 years, and some use of sedatives, in this case, Xanax. This is a big family, so she's the eldest child. And the reason why we're providing services is because, issues at school. So she was caught at school under the influence. This is the first time that she has accessed substance use counseling services, no inpatient. Unfortunately, there has not been any mutual aid or non-clinical support services. Nothing on medication assistance. And client is already midway through the outpatient, since that is the type of level of care that we are providing in our agency. She, as far as the symptoms of mental health, there is some depression and some anxiety, but there has not been any formal or mental health services provided. Again, for that, negative views about it. And there has been no ACEs or adverse childhood completed with her, but and here in the presentation, yes, the clients or the separation of her parents does tie a lot into the self-harm, which was the last episode, 11 years old. That's when the onset of substance use also initiated. And although there has not been that true acceptance or confirmation that, yes, because my parents separated, this continued, but there is still that struggle as far as mom and dad are no longer together. Some of the interventions, again, they're provided, and yep, the client is on that contemplation stage of change. So any questions or possible different approaches that maybe we should be including?
Thank you, Cindy. We're going to open the floor to hear some alternatives or options here.
Are the parents involved at all?
Yes, again, they are, but this is one of those cases where, what do you mean, my child? So no awareness of the substance use from the onset until it was recently reported by the school administration. And yes, but also even parents are struggling or have struggled in what is substance use, what are the types of support out there. And so they are involved to the best of their abilities as far as being able to at least come to some of the sessions, but in this particular case, it's also the youth that at times that treatment difficulty and adherence is I'm good. You know, I don't feel like going today, so to speak, but they are involved. Thank you.
What do you, how do you think about and what do you know about the self-harm? And it seems like chronologically, when that stopped, this began. What do you think about that? What does she talk about, the relationship between those two things?
It was mainly, or it has been mainly, as far as, you know, whatever the circumstances that led to the separation. I think it has to do a lot on what you were mentioning, and most definitely as we see the association or the association of I'm not a good child, or causing, if need be, certain issues at home, that then mom and dad are no longer together, self-harm, you know, that's the only way of her, if need be, coping with that. So there is some guilt or shame, like you mentioned, as far as the emotion component of things, of what could have been the actions that the family or the children have done, or in this case, her, that maybe caused or affected and led to the parents that separate.
And so, like, is that the similar trigger for using substances, feeling like something's my fault, like I caused this, and that
Yes.
then
Primarily has
I
been
want
as
to,
far as, you
yeah.
know, just using to forget and to block that. And or not to, the way that she can deal with the fact mom, dad are not longer together. Although they are in the picture, but it is that of the unhealthy relationship, or the connotation that she has of they're here, but they're not together. And they've already, you know, continued with their individual lives as well.
What does that mean to her that they're not together?
As far as, well, on that one, that's a good question. Maybe no, that has not been explored in depth.
Yeah.
And I think it has been more so on what it is, or what, and through her interpretation, is the case, as far as acting out, you know, mainly acting out, therefore separation.
Well, and it makes me wonder what's changed since they're not together, right? Sometimes when people, prior to separation, the family is like a lot of fighting, and then maybe there's less fighting, or maybe it's that I now never see my dad, right? Or there's more fighting, right? Like, so I think like it'd be interesting to understand a little bit more about kind of what exactly about not together, right? What that meaning, right? What potential like triggers related to maybe I have to go see my dad, or maybe he bailed again, right? Like what kind of what specific?
Okay, yes. Unfortunately, I don't think that I have all of that information as far as that
Of
goes.
course not.
But it thankfully, what I do know is that yes, it wasn't anything as far as abusive relationship, or any type of domestic instance. But the separation, as far as the details of it, yeah, I mean, that could be a good one as far as continue exploring on that through the
One of the great things when we like think from a CBT lens is like we are never going to have all of the answers, but it's about kind of putting on kind of a curiosity and like, yeah, that theme still it keeps coming up. And so how is that shifted? What is it about that? Like, and understanding like how does this use impact that? I guess that one other thing is what does her use pattern look like? Right? We're kind of assuming we know she got in trouble at school, but I'm not sure how what it looks like, and we're kind of assuming that it is a big problem. Yeah.
Mainly, or some of the use does happen at school, either before or after
Okay.
school. So there is, that also skipping from some of her classes. And then at home, well, not at home, sorry, after school, with other friends or other acquaintances that are not that one trusted friend. But primarily it's at school. And again, that is due to, well, there is no parental in this case, right? Of course, although there are other types of supervision, but it's primarily on that. And unfortunately, at least here in our area, that is unfortunately that commonality that the schools are tremendously struggling and finding more cases as far as the use or the increase of use, even if it is in a restroom break or during lunch break, again, before and after school, but yes, primarily has been that.
Didi, you wanted to say something?
Thanks. I think there's a couple of things, and one of them would be, I'm curious if anyone has explored medications with her. And since she's using to cope, it's like, well, then let's give her something, that maybe that would be helpful. If she could transition or titrate from the cannabis more over to something else. And maybe she's not interested, of course, but that could be something to explore. And then again, exploring what's keeping her from being able to engage in sports at school. Is that something that the school can help with? Because that could be tremendously helpful on a physiological basis, especially.
Hi there. I also had a question just about, I know you were bringing the case forward for treatment adherence. And is that because of her unwillingness to come to,
Confession.
okay.
Yeah.
Or is there anything else around that? Or is it mostly
No,
that?
it's mainly that. Also, as far as what you mentioned, the medication, in or towards the mental health, to formally or officially diagnose if there are any mental health diagnosis. It's that resistance and or sometimes unwillingness to further explore that with a different provider. Because that is a little bit on that of I don't trust. And so we're at least right now with the substance use, and although we would want to explore the different other components, when the counselor poses, let's refer you or let's connect you with a mental health provider, well, pretty much on that of I am not gonna go over there. I'm just gonna, do you want me pretty much to continue coming here or going over there? So it is a little bit on that as far as, the psychoeducation component has been a little bit also on that on how all different types of services can be most definitely beneficial, but also necessary should there may be a different or different aspects of things that need to be treated in a different way or a different manner than all hands on deck. However, again, we are still rooting for, hey, you're still coming into treatment, celebrating that and acknowledging that the autonomy, although we would want to see it across all areas, but she keeps on continue coming back to the substance use treatment.
Yes, and Cindy, you wrote in the case form that maybe a positive aspects of the situation in general is that she says she's looking for reasons to stop using. Has she said that openly like that?
Yes, mainly it has to do with the relationship between her and her parents, biological parents, more than anything, like paying back on regaining trust, exploring more positive aspects of their relationship. Because again, no awareness of substance use going on, and then parents getting a call about the school, letting them know, of unfortunately the substance use involvement. And this is of, what are you talking about? I always pick her up. I am, present. I'm working.
Yeah.
I am tending to other of my children.
They don't want to look like bad parents,
Yes,
basically.
yes, most definitely. So it's mainly been, again, on that wanting to regain the trust between parents and her. Fully trust, I would say. No, I do see a question in the chat. She has not engaged in mental health professionals, but this of, in school, if any other friends or any other classmates share experiences. So I would say then it is the external experience or third party experiences with mental health.
So other people say this isn't helpful, but her family is saying like this is like you should go to therapy. This is helpful for you.
Mm-hmm. Yes, it's now also just exploring more, or once a counselor hears the yes, send me the referral, then going and moving forward with that as far as the mental health.
Sounds like, one of the most important things for her is to regain this trust of parents. I guess the question is like, what would that look like? How would she achieve that? And what are the parents, how have the parents' behaviors changed? Like, what are her like negative consequences? What does that look like that she doesn't have their trust anymore?
Okay.
Do you know?
No cell phone, no going out in regards to, if that trusted one friend, it's only at school. So mainly.
Yeah. I wonder, like, what would the parents say about what do they need to see to for her to earn back some of these privileges?
Mm-hmm.
Because that's kind of like, it's like almost, if we could get the whole family on the same page, right, then that can help her to have a clear path of, getting back those privileges. Do you think the family would partner with you in that way?
Oh, most definitely. I do think that that could be another approach that we can utilize for sure.
Yeah, because that would help you get really specific, right? What does it have to look like for how long? Like, and it doesn't have to be, I think, as parents, sometimes we struggle with this, like, you lose everything, right? It's forever. Like, but it's about kind of earning, right? Trust is earned. And what does that look like? And how, if you could set up some, ways in which she can earn it and then also help the family stay consistent, because it's kind of hard, right? Sometimes as a parent, then a client or our child has, they go back to this bad behavior, and we're like so frustrated that we explode, and then we react bigger than maybe what the plan was, right? So that might be helpful for the whole family.
Absolutely. No, thank you so much. I will.
Thank you.
That.
Thank you so much, Cindy, and thank you, Dr. Dondanville. I guess it's almost 1, so I don't know if there is time to go through a brief summary of the case and some recommendations, but I don't know, it's
Okay.
almost 1.
Yeah, it's a great case. We really appreciate everyone, bringing this type of case and I think many cases are like this, and it seems like there's this opportunity to maybe kind of dig into what's most important to her and leverage like this active family and focus possibly more behaviorally, and getting access to a phone as a 13-year-old, like that is a powerful motivator. But I think, you've got some good plans in place to think about how to help them all work together for her to regain some trust. Maybe a strong incentive.
Thank you so much, Katie, and thank you to all of you, to our hub experts and our learners today. Remember to answer that post-session survey that we will be sending, and we'll see you next month in the same space. Thank you and have a great rest of your day. Bye.